And shall we start? It's 4:59. Well, 7:59. So we'll wait to start on the dot.
Yes, sure. Anytime.
Okay, might as well. So good morning, everyone in the Philippines, and good afternoon here or good evening in the US. I'm Joel Coelho, and I'm a professor here at Biosystems Engineering. And I'm pleased to serve as co-host this morning in the Philippines for the PAASE webinar, for the simple fact that our regular webinar host is speaking today. So today I'm joined by our other co-host, Ann Villalobos. But before I introduce her, just going through the housekeeping rules. So please mute your microphone, and we encourage everyone to post your questions on the chat, and we'll go over them at the end of the presentation. So I'm pleased that I'm co-hosting this today with Ann Villalobos. Ann is a chemist, and she actually worked for Johnson & Johnson, who, as we all know, developed one of the vaccines that has already received emergency use authorization by the Food and Drug Administration here in the US. It's called the Janssen vaccine. She actually worked for Johnson & Johnson for 18 years. And she's currently in the Philippines because she was engaged in her Balik Scientist program just before COVID hit the country. So she's currently there. But anyhow, I want to turn it over to you, Anne, if you could kindly introduce the speakers and we can begin. Thank you.
Thank you, Joel. I'd like to introduce John Frederick Tapia. He's an associate professor in chemical engineering, Department of De La Salle University, Manila, Philippines. He is a graduate of PhD in chemical engineering at De La Salle University and was a postdoctoral research associate in University of Bath from April 2018 to October 2019. As an early career researcher, his research interests include process systems engineering, PSE, of low carbon energy systems, mathematical modeling of biomass value chains, specifically oil palm value chain and geographical information systems, or GIS, based analysis of suitable lands for oil palm. He has 24 Scopus Index research articles in various high-impact journals in energy and environment topics. His current age index is 8. He is very young. And the other speaker is Kathleen Aviso, or Kay. Is a university fellow and professor of chemical engineering department of De La Salle University. Her main research interest is the development of computer models and decision support tools for environmental decision making. Her work has been applied for the design of sustainable industrial systems, such as eco-industrial parks and low-carbon energy systems. She is the author of more than 160 Scopus Index publications with an H index of 26. Wow. She previously served as associate editor of the Journal of Cleaner Productions since 2018 and is currently one of the executive editors in the Journal of Cleaner Production. She is also a part of the editorial board of Process Integration and Optimization for Sustainability, that's Springer Nature, Computers in Industry, Elsevier, and Helion, Cell Press Elsevier, and is author of the book Input-Output Models for Sustainable Industrial Systems. That's the Springer Nature. So with all these talents, they are ready to present to you how to allocate COVID-19 vaccines, and we will hear a lot from this program. Thank you.
Okay, thank you very much for the introduction, Anne, and thank you so much, Joel, for making this possible. So thank you, Joel and Anne, for agreeing to moderate this particular session. So good morning, everyone. So today we'll present the work at De La Salle University on how to allocate COVID-19 vaccines. Okay. So just to give us an update on what's already happening. So this is our scenario, the global scenario right now. We're already a year into the pandemic. So I can still remember that last year, it was also my mother's birthday when we started our lockdown at De La Salle University. And now she already had her birthday again yesterday. So this is the scenario. The coronavirus has actually infected over almost 120 million individuals and has reached more than 2 million deaths. Now, going closer into home, these are the statistics for the Philippines. We have 600,000 confirmed cases and already more than 12,000 deaths. And although late last year, we already started seeing the decline in new active cases daily. In the past weeks, we have seen a sustained growth in the number of infections again. And now we see on the news that some cities are already starting to impose lockdowns and curfews. Now, we do have a mix of good and bad news. The good news being the vaccines are slowly being deployed, and we now have a variety of available vaccines. However, we can also see a rise in the number of variants. So there's also an increasing number of variants, and the efficacy of the available vaccines with regards to this new variants are still unknown. So the question really is, do we vaccinate the vulnerable or do we vaccinate the vectors? I suppose this is the main question for our governments. And this decision has, but however, the decision on which one to prioritize is something that needs to be identified by the government on behalf of its constituents. Hopefully, this model will help in this particular decision making. However, the decision on whether which one to select is really a preference that has to be made by the decision makers or our government. And the models are really here to support that particular decision. So it is not meant to be independent from our policymakers, but instead are meant to support their decisions and ensure that the policies that they set are actually consistent with the goals that they meet. And the models will provide them with a solution or with an answer or on how this particular goals or the objectives can be achieved. So even last year, early on in the pandemic, the De La Salle University group of researchers has already thought about these these problems that we are already facing right now. So some of my colleagues, including Dr. Raymond Tan, Dr. Louis Razon, and Dr. Derek Yu, have actually published an article in Resources Conservation and Recycling way back in April 2020, um, highlighting the importance of pharmaceutical supply chains. And as you know, we actually expect that there will be problems with regards to scale up. So we also had a publication in April 2020. So this was the first published article globally with regards to models for allocating COVID-19 antivirals. So for this particular work, it was a model for allocating antivirals to try and reduce um, the severity of the infection of COVID-19. So if anyone is interested to know more about that article, so you can actually click on the QR code, scan the QR code, and it will direct you to the article. So it's an open access article. So for this particular publication, what we considered was that the introduction of the antivirals can help reduce the severity of cases so that it can also help alleviate overwhelming the capacity of our healthcare systems. So we considered resources that might be needed depending on the severity of the cases. And just to show you a summary of the results, so we considered different scenarios which looked at the availability of different antivirals, which might have different efficacies with regards to its potential of reducing severity of the infection. And we saw that by using these models, the models can inform the decision makers on how to properly allocate or distribute these antivirals so that it can greatly reduce the total number of deaths of infected individuals. And though this might be for the antivirals, a similar case or a similar model can actually be extended for vaccine allocation. And this is what this project is all about. So I'd like to introduce the team. So Dr. Charlie C, so she's also here in the audience, is actually the project leader. So she's a faculty and an associate professor of the Industrial and Systems Engineering Department of De La Salle University. I serve as the project co-leader of this particular project. And our next speaker, who is Dr. John Frederick Tapia, is the one leading the team for app development. So the three of us have a combined publication of almost 200 Scopus indexed articles in the field of optimization and modeling. Now with us are a big team. So we're a big team, particularly because this particular project wants to look at different aspects. So it looks at model development, it looks at public dissemination, creation of policies, and looking at sustainability and deployment of the app. So the components of this particular project include model development, like I mentioned, public dissemination, creation of policy recommendations, and deployment planning. And I will cover some of these topics in this particular talk. So there will be more focus on model development, and then deployment will be discussed by Fred later on. But the other team members are actually here in this particular forum. So if you have questions later on, with regards to other aspects, feel free to ask them. And some of my team members are here to address those particular questions. So let me start off with the first model that we developed uh, for the allocation of the vaccines. Earlier on, I asked the question on whether we should vaccinate the vulnerable or should we vaccinate the vectors. And these two, although they might sound similar in nature or they might seem to be of similar objective, they are not exactly the same, as we will show here in the models that we have done. So this model is intended to provide recommendations of vaccine allocation for the general population. So we actually developed two types of model. One would be minimizing the infection rate, or R, and minimizing total fatalities. So the models that we developed were implemented in Lingo and MATLAB software, which are proprietary. And now we are looking at deploying this version to more accessible interfaces such as Python and Microsoft Excel. Okay, so for the first model, these were the model parameters that we looked at. So we looked at the fatality rate for the different age groups. So as we know, even early on in the pandemic, depending on your age group, it also greatly affects how severe your reaction is to the virus. And then we looked at the availability of vaccine. So as we know, there will be scarce resources for the vaccine. So not everyone can be vaccinated. So the problem really is, who do you prioritize? And then we look at the next generation matrix, which I will discuss later on, um, and parameter for the efficacy of the vaccine. As we have seen, the available vaccines have different efficacies, and the size of each population group. And as a result, or the model output, the model is intended to indicate what proportion of a population in each group should be administered with that vaccine in order to achieve the desired objective. Okay, so let me discuss more about the next generation matrix. So we are all familiar with the R naught, or the reproduction number of the virus. So the next generation matrix really is a more detailed calculation, or more detailed look into how the infection progresses from the different population groups. So this matrix, for example, shows us how an infected individual in one group infects individuals in other groups. So in a way, it also captures the mobility and the contact between the different groups considered in the model. So this was the first model, which is a linear model, which intends to minimize fatalities. So minimizing fatalities translates to vaccinating those who are more vulnerable. Because as we have seen, those who are vulnerable would probably have more severe conditions and would have higher probability of fatality. So this would be the overall objective function, wherein alpha is your fatality rate, which would depend on the type of population group. Then we have the total infected population, wherein we integrate the next generation matrix. And then we have the total of vaccinated individuals. Now, some of the constraints for these model includes identifying the total number of people vaccinated in each population group. And we have to ensure that the proportion receiving the vaccine would total 1 for the entire population. And that completes the total available vaccine for any total amount of available vaccine. So we did some initial runs, and these are our results. So I just like to highlight that we did this for hypothetical case study. However, this gives us insights on what can potentially occur based on the availability of our vaccines. So we looked at a variation of vaccine availability, and we actually saw a change in the trend on who should be prioritized when giving the vaccine. So if there was only 10% vaccine availability, for example, the priority group was given to those who were really vulnerable. But later on, the allocation shifted to the group 4, which are in the age group of 35 to 44, when there was an increase in availability. So this was primarily because you are already able to vaccinate those in the vulnerable region or vulnerable group, and so um, an additional available vaccines would then be administered to group 4. Okay. However, when we did this particular model on prioritizing mortality rates, on the reduction of the mortality rates, we did an assessment on how the infectious rate was affected, and we saw that it was not sensitive to the infection rate. So even if there was an increase in the availability of the vaccines, we only noticed a slight reduction in infections. So now let's move on to the second model, which will be presented by Fred. Okay, Fred, just let me know when I need to move on to the next slide.
Okay, so hello everyone. So for the next phase, we- I'll be discussing the model which is nonlinear in nature, but it allows us to see or determine how the each population group interacts with within um, the population or the total population, and how we can allocate the vaccine based on this interaction. Next slide, please. Okay, so for this nonlinear programming allocation model, we want to minimize the spread of the virus or the disease by minimizing the reproductive number. So as shown, we have a two constraints which the first one, the long inequality, shows how the infection or the disease are spread and how it can be minimized by applying the vaccine. So in this case, we want to minimize the R using which is an solved or which is indicated by the eigenvalues um, given or or given by the values in the eigenvector V. So the next generation matrix K um, is a parameter which allows us to know how each population or each population group infects uh, one after the other. And the model is based on the paper by Enayati and Ozaltin, in which the next generation matrix is based from the equations that we know from the dynamics of a disease. Next slide, please. So we still maintain the same set of constraints. Now, to illustrate the model, we have the two vaccines given the following efficacies: 98% and 90% respectively. So for the first vaccine, we have 30 doses, and then for the second vaccine, we have 100 doses. So by applying the model, next slide, please. We have a next generation matrix which consists of five population groups given in the table on the right. And then the population of each group are given in the last column. Okay, so by using the model, the results suggest that we allocate the vaccines to the population group B. One of the reasons may be because the infection rate within Group B, as shown in the second cell, second row, second column of the matrix, which has a value of 1.7, shows that for every individual in the Group B, um, it is likely that it will infect around less than two individuals in the same group. So these vaccines, vaccine 1 and vaccine 2, are allocated to both, um, these vaccines are allocated to Group B, giving a result of an R value of 1.19. So this means that given the limited vaccine, the infection or the disease still um, spreads. And the only way to minimize it is to allocate the vaccines to the second group. Next slide, please. So some initial insights from these two models are the following. First, there's um, an inherent trade-off or a decision that requires us to determine uh, who to which group or which has to be given with the vaccine. Is it either the vector or the ones that um, um, quote unquote spreads the disease, or the vulnerables or the individuals that may die or may develop severe cases. Now, with regards to the vaccine availability, so there is a diminishing returns based on the case study, as when the vaccine availability is at 20% or more. Now, for the model, there are a lot of unknowns. So we need to determine with accuracy or with preciseness the um, the value or the data that we will use for the model. And the model should be continually updated as new data becomes available. Next slide, please. So, as part of the app development team, so I'll be presenting the deployment plan for the models. Okay, so next slide. So here's the app developers. I'm in charge with the coding or translating the mathematical program or the equations into Python code. And then Eunice and her two students, Josh and Ian, are in charge with the development of the app itself, connecting the user interface and the models. Next slide, please. So how do we tie the pieces or the features or the codes all together. So I have the code for the optimization model, which uses the Pyomo package in Python. The user interface was developed using React in JavaScript, and then the um, the the model and the user interface are connected using a web framework using Flask. So the structure is as shown where the users put the following inputs: the groups, the vaccines, and their parameters or the information regarding the groups and the vaccines. For the groups, we want to determine the population of each group and the next generation matrix, which to to laymanize or uh, to allow or to allow us to translate the next generation matrix into non-mathematical terms. We use the term contact rate. And then for the vaccine, we just need to specify the vaccine efficacy. So the user input is translated into model parameters and put into the optimization model. So the model solves, then the output is displayed in the interface as the vaccine allocation. Next slide, please. So to operationalize the model, we again the 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 model is translated into a Python code, and then we have an online web application built using Flask and React JS. So the app is still in development to incorporate or to incorporate other models like the one presented earlier, which to minimize the fatalities. Um, here's a preview of what we have developed for the deployment of the allocation model. Next slide, please. Now, the model supports the app supports multiple models. Two of these are includes the minimize the required vaccine given or to minimize the number of vaccines to stop the spread of the disease, um, or we want to determine how many vaccines we need subject to an R value of less than 1. And then the other one is to minimize the itself given the limited supply of vaccine. So it's more of it depends on the user on what information they have. It's either they have secured the supply or they are securing the supply. Next slide, please. First, the population group should be indicated together with their populations. So in this case, yeah, it's a data that can easily be obtained from census or from, say, local health office. And then next slide, please. The user set the contact rates, or the user creates the next generation matrix. Now, if the next generation matrix, since it's based on differential equations, whose parameters are entirely different as that of the next generation matrix, we will be incorporating some predefined values for the contact rates. One set of which includes the next generation matrix shown earlier from the paper of Yu et al. Next slide, please. Now, once the data has been put into um, the the model, um, the app will solve for how much allocation for the vaccine in each particular group. For the minimized vaccine require, our approach is, or for this one as shown, it only has For the demonstration, we only have one vaccine, but in the future, we'll incorporate multiple vaccine allocation for this model. Next slide. So with that, some concluding remarks. We have um, COVID vaccines have been developed in record time due to the change in policy while maintaining the protocols for safety and procedures for the proper clinical trials. However, production ramp-up will be a challenge since the vaccines are high or have high demands all over the world. Thus, for example, in some countries which the vaccine procurement is would be a challenge, thus giving them limited supply of the vaccine, and so the allocation should be optimized due to this problem. So the model again, it gives suggestions or insights to the user as to how the allocation should be made. But the actual plan should not be um, based on the numbers given by the model on it in its face value. And then next slide. So what's next? Um, for us, or for the project, we will be having some testing of the web-based app. Then I will be calibrating the a model to, like what I've said, to account for multiple vaccines and new variants. For the third one, we'll be developing some plan for the deployment of the app for public good. And then we have granular or small changes with the models as time goes by. And with that, thank you very much. So here's our email addresses if you have further questions after this talk.
All right. So thank you, Kathleen, and thank you, Fred, for your presentation. Anne and I will be the first ones to ask you questions. So I have a two-part question, Kathleen and Fred. So the first one is regarding the representation of your model with equations. I'm sure there's a simple explanation to it, but I didn't see any time function. So I'm assuming it's embedded somewhere in the equations, but I'd like for you to please explain that and elaborate on that.
Okay, so at the moment, the model is not dynamic in nature. However, it is the next generation matrix that integrates, for example, the dynamics of the infection across the different population groups. But no, yeah, the time element has not been integrated yet.
Okay, but it will be, yes. Okay, that's fine. So now I kind of, my second question is focusing on what the model could potentially provide in terms of providing assistance to the government and the population at large. So I know that your stated goals for this at least initial study is reducing fatality as well as reducing the infection rate. So I know that there's a limited supply of vaccines right now, but eventually, of course, over time, there will be a sufficient supply of the vaccine. It's going to be a mix of the vaccines. So ultimately, the goal for every country, including the Philippines, is to achieve herd immunity. So be able to vaccinate a sufficient proportion of the population to arrive at herd immunity. So what would you need to do with your mathematical model? How would you extend it so that you would be able to provide answer to that question
Okay, so
of achieving
yeah, so I
herd
think
immunity?
Yeah, I think Fred also presented a variant of the model, which is on minimizing the amount of vaccines that a particular population or a region would require. So if you can, if the vaccines would become available, then the next issue would probably be on cost. So you'd want to be efficient with the way you disperse your budget. And so the model can be modified so that the objective is really on minimizing the total amount of vaccines that a population would need in order to keep the contagion in check.
Okay, great. Okay. Anne, I'll turn it over to you.
Well, thank you, Joel, and thank you for those questions. Actually, my main question here is application to the Philippines.
Mhm.
Has is this model being considered by the Philippine government?
Okay,
Have you
okay.
shared it to them?
Okay, so at the moment, it's not being considered. However, we have had some talks with okay, we have had some talks with some government agencies. So I'm not sure if Ador would like to provide more details on his discussion. So Ador is part of the team, and he is the current director of the Jesse Robredo Institute of De La Salle University, and he's the one who is leading the team with regards to yeah, policy formulation and trying to be more in touch with the local governments. Ador, are you there?
Yes, I am here. I
Okay.
didn't fully catch the question. Can I
Okay.
have the last part of the question
Okay.
again?
I think the question was whether the model has already been being considered by our government. I was just wondering if you have additional information on
Uh,
your
okay, right
yeah,
now.
your talks
Yes.
with
Hi, good morning.
good
Yeah,
morning.
right now I think the Philippine government has not yet looked at these models, but the policy has actually been more of a priority list of who gets the vaccines first. So there are, I think, three levels of priorities that had been issued. The first being frontline health workers, senior citizens, indigents, frontline workers like police officers, security sector. The teachers and academics come with the second level priority, along with some others who are younger and less vulnerable. And then you have a third level priority who does not belong to anyone else. So what we've seen in practice is that this is just a general list of who's supposed to get the vaccines first. However, in actual practice, there has been a lot of, shall we say, the non-strict observance of who actually gets the vaccine first. So we've seen the frontline workers get the vaccine first, but we've also seen a lot of non-qualified. They don't belong to the top priority officials and groups having receiving the vaccine. So I am not sure what kind of model the Philippine government is doing right now, but the general instruction is that for all of the local government units and all of the agencies that are supposed to get the vaccine, they should be following the priority list. I've not encountered any models that they are following.
Okay.
Thank you.
I would
Can
like
I
to
have another?
call. Oh, go ahead, Anne. Go ahead.
Can I have another concern, especially with the Philippines? I know how will the model address a problem wherein the vaccine is already in the Philippines, but in other countries that vaccine has been uh, how do you call this, suspended because of some serious side effects. How will the model approach it? I know you mentioned about the variants and so on, but how about the ones that are already under emergency use authorization in the Philippines, and those vaccines are already that vaccine is already in the Philippines and yet suspended in other countries.
So, like I mentioned earlier, so these models are really meant to support decision making, and they can be calibrated and modified based on the preference of our decision makers or any additional information that may come in during the time of decision making. So, in instances wherein certain types of vaccines, for example, um, Okay, so if certain types of vaccines are available, and then all of a sudden they will not they prove to be suspended from others, then decision makers can actually consider either putting a constraint within the model so that these will not be considered in the allocation, and that only those that are that are priority, that would be the priority, can be utilized. Okay, wait. I just want to ask my team members if you have any additional if you have any additional inputs.
Well, if I can chime in a
Yes,
bit.
please.
This is Raymond, by the way. I'm peripherally involved in the project as from an administrative standpoint. And I think we should emphasize that the philosophy that we're applying here is, by analogy, it's very similar to a medical doctor with a patient. So you give advice on what should be done for health. It's not our place really to push the issue if the patient does not wish to follow doctor's orders. But what we do is we try to give the best advice possible, best computational capability, but it's not for us to push for any kind of agenda or any kind of advocacy per se. Okay, thank you, Kay.
Yeah, I think what Raymond, what you're saying is that it's a policy matter, and so the decision will be made by the government. Yeah. All right. Thank you. Al Serafika has a question, but I'd like for him to please to unmute and verbalize your question.
Okay, thanks, Joel. Guys, if you have not been able to join the session yesterday with former Secretary DOH, Secretary Diary, Edsel Salvania, and Dean of UP Medical School, June Belisario, there are new data on the front that actually invalidates most of your assumptions in the model now. There's clearly the incoming schedule of the vaccines has already been laid out. And by June, we will be receiving close to 11 million vaccines. And his problem now that he's posing to the whole community, the scientific and the medical community, is how do you administer that vaccine so that they will not, one, laid to waste, not expire, and two, be able to actually achieve what it's supposed to do, which is mainly at this point, not going after herd immunity. It's really reduction of severity as well as death. And transmission blocking capability of these vaccines are not being established. So we should not be talking about herd immunity. We're just talking about delivery. He had a very nice graph where he showed that our current capacity at 10 to 20,000 jabs a day will be needed to be scaled up 10 to 20 times in order to utilize this incoming vaccine rate of about close to 11 million. I have a graph of his. I don't know how to share it though, but it tells everything that we need to even get up high as much as 500,000 jabs a day in order to use and not waste these vaccines that are incoming. And we will be in a vaccine glut 3 months from now. So to me, the model that we need to be looking at this point is how do we deploy the resources needed in order to increase our vaccination rate rather than allocating vaccines, which are going to be incoming pretty soon. And again, this number can change with the numbers, new contracts being administered with Bharat, India, Novavax. So, but this is the base numbers that Secretary Diary provided, and it's already a glut by June. So I think we need to get in front of the 8 ball and really reassess our model in order to address this. So I don't know if you want to see the graph, but I do have the picture. I don't know who can, I can send it to a Viber to everyone will be on the same page, hopefully. Thank you.
Okay, let's have Kathleen respond.
Okay, yeah, thank you for that, Al. Actually, I think the problem that you're posing would be more suitable for supply chain model. And actually, we've done initial work. We just didn't present it here. We just didn't present it here. But it was a transshipment model on allocation, on how to get the vaccines from the source to the endpoint. Yeah, but yeah, that's in our
Okay, Giselle, do you have a question?
Yeah, I think
Unmute
Giselle
yourself
has
first. Yeah.
Thank you, Joel and Kay. I'm sorry I have to leave in a short while, but I just wanted to tell everyone that the video recording of yesterday's chat is already posted on the PAASE website. And I asked Kay to attend the chat yesterday. Very informative, Joel and Annabelle. Thanks for that,
Yeah.
Al. I think what we also wanted to emphasize is the the fear of Secretary Manolet Dairit of wastage, okay, because the vaccines will expire in July. So,
Mm-hmm.
okay, I think it is important that we share with everyone that supply chain study that you have made. My second point is this. I'm very much aware of the allocation program in the United States because I do have children there. So, anyway, it's per state, and we've heard the leaders of the NIH, the WHO, and the CDC speak about how they are allocating vaccines in the different states, and it seems to be a successful program based on the number of vaccinated Americans today, and there is a priority per state. And we know that each state has a way of deciding their priorities, but
Mm-hmm.
by and large, they seem to be the same kind of priorities of allocation. That's all I would like to say. Thank you so
All
much. But
right.
please,
Thank you, Giselle.
yeah,
Thank you, Giselle.
watch the chat.
Okay. We get a question from Eno. Eno, would you like to ask the question, please?
Okay, thank you, Joel, and congratulations, Kay. My question is, aside from the temporal aspect of the allocation, uh, can the model also be adapted so that you can consider geographical differences, such as distribution into provinces and regions?
Yes,
Thank you.
I think yes, it can be customized so that it applies more to regions. But so essentially, what information you would need would be more of the characteristics of infection rates and contact rates in that specific region, and yeah, the distribution or demographics of the population.
May I add?
Yes, please, Fred.
Okay, the model essentially is would really depend on the target region at first. Like, let's say it can be on a school. It can be say a particular city, or it can be a particular say region in the Philippines. The how the model would solve or will give us information as to how we allocate the vaccine would depend on how we define the population group. Like for example, for the schools, we may define it as the a population group for, let's say, within students, within teachers and administrations, and within or students, teachers and administrators, then staff. And then for say for example, um, for locals or for cities, a different population group may be defined. And then for the, let's say, for a larger region, like for example, uh, regions consisting of provinces, a different um, a different population group may be established. The challenge is the challenge here is to define the next generation matrix based on the um, what population group we establish, and the next generation matrix based on the paper by Enayati and his colleague is based on the differential equations that we know or that we have to model the dynamics of the disease. So yes, it's possible that it's possible aside from the demographics by age, we can also include uh, demographics by location.
Okay. And all right. So Anne, I think is not available right now. So let me ask this one from Gary Emerson. Other than refining the model to account for time, should it also incorporate externally introduced factors such as government mandated priority list? When might we see a recommendation based on a refined model that could be used by our regulators?
Okay, so
How would you answer, Kathleen?
yeah, okay. So with regards to the policy. So essentially, yeah, the model is meant to support like the priorities of our policymakers. With regards to availability on deployment, Fred, do you have any update on that?
With regards to the deployment, we are still on the refining side, or we're still in the refining stage of the app itself, but it will be available soon once we have a a model that can be perfectly, or that can be um, that can be used, or um, that can be deployed and used by the public. So it's just a matter of refining now.
Okay. All right. So we got a question from Hill Mendoza. I have a multi-part question. Can you give us a sense of the computational time to get a solution, perhaps in terms of model size, number of variables, and constraints?
Okay.
The next generation. Yeah, go ahead, please.
Okay. So let me just answer that.
Yeah.
So at the moment, since this is like a shell model, and you've seen that the groups were limited to around 5 or 6, so the computational time was just really slow. I think in a matter of seconds, it can be easily calculated, especially for the first model since it was a linear one.
All
But
right.
but we do expect that the computational time might increase if there are more complexities integrated into the model.
Right. Okay. The next generation matrix obviously drives the model.
Mhm.
The model is static, driven by the matrix with constant rates. Can this matrix be unpacked so that each cell entry can be made endogenous to be determined by the model itself?
So at the moment, the formulation is just static. We haven't explored looking at endogenous values. But I think the next generation, the calculation of the next generation matrix is actually dependent on um, other models like those being done for the SEIR model. So it was actually a result of the SEIR models. So essentially, it would require the integration of multiple types of models to make that possible. We haven't explored that yet, and if it does happen, it means that the model will be highly nonlinear, and we expect longer computational time for such occasions.
And finally, how about the spatial dimension of the spread? Similar to the Lansigan question, I think about geographical considerations.
Fred, do you want to respond to that? Spatial.
Like what I've said earlier. So it's well, we do consider one model that considers some information related to geography, but those the information given are independent, and does not consider the interactions like the one that we use for our project. So um, the geographic consideration in the model that we are using is mainly by setting the population groups based on location rather than by other factors like age.
Okay. Is Al Serafika still around?
Yeah, I think
Al,
I'm here.
I think he's still there.
Yeah.
okay, Al, I'd like to have a follow-up on the comments that you provided, if I may. You mentioned that, and I forget, it's the health secretary or former health secretary informed that there's going to be a glut, meaning to say an excess of vaccines by July. Is that correct? Can you confirm
Correct. By
that?
June, actually, they're estimating based on the orders and the delivery schedule, there will be 11 million vaccines available, and we only receive right now close to 1.5 million. There's a graph that I just emailed
Right.
there's a table and a graph actually that
But why?
demonstrates the
My question is,
need
why
to
is that?
administer it fast.
Right. My question is, why is that considered a glut of vaccines, an excess of vaccines, when the Philippine population is over 100 million?
Because the ability to administer those vaccines, Joel, is at the rate of 10 to 20,000. We need to get up to 200 to 300,000. But if it's going to be an 11 million delivery, we need to jab 500,000 a day in order to utilize before expiry of those vaccines.
Okay, so it's
That's
a
the big
question.
problem.
It's a question of deployment then.
Yeah,
so
it is.
that the
Employment and
vaccine-
administration. We don't have enough healthcare workers. We don't have enough delivery vans. We don't have enough, even the supplies from syringes to cotton buds to band-aids. All of those need to be taken into account beyond the logistical nightmare that's going to be encountered once those guys come in. So,
And that is
we only
time.
have 3 delivery guys right now. We have Royal, we have Air 21, and we have Swilling Pharma that are doing the refrigeration deliveries. So it's gonna be a mess. So I'm telling you the mess 3 months
Okay,
ahead.
point well taken. And it has to be administered because it's time sensitive. The vaccines could go bad. So Kathleen, I'm directing that to you. Is your model configured so that you're able to address that?
Okay, so actually the one that Alice talking about will require a different type of model. Yeah, so yeah, but these things, yeah, I think this is a good example of, parang knowing, parang you did this particular decision without consideration of the other complexities
I
the
messed you up.
surrounding it. Like if we did a model earlier on and actually found out what our capacity rate is for administration, then we could have scheduled the
Yeah, sorry. I mean, it just happened
coming.
yesterday. I was shocked. Also, I was shocked. I thought we were in a very very dire straits in terms of vaccines, but only to be told that 3 months from now we'll be swimming in
Yeah, then
vaccines.
that would be a waste if we
Super
won't be able
waste of money
yeah,
and resources, guys.
exactly.
This is we owed 1.3 trillion based on this. I think Secretary Pernia is already here. He can talk about the cost of this vaccination. So I hate to see it in the waste. Go to waste.
Yeah,
Joel, may I respond to Al?
yeah.
Yeah, please.
This is an entirely separate problem.
Yeah.
In other words, that requires essentially shifting gears. The good news is that's a lot closer to the core research that Charlie C. has been doing, and Kay as well, and Fred. These are supply chain problems. Would be a lot easier for us as a research group, or for them. By we, I mean them. To ramp up the research and development because it's closer to what they've been doing historically. So thanks for the tip. We'll look into that.
Thank you.
Right. Yes. Secretary Pernia, hello.
Yeah, I think
if you could unmute yourself, and if you could provide us some comments, remarks. Please unmute yourself. You need to unmute yourself.
Yeah. I'm sorry.
All right.
Okay. Yes. As I was saying, my question is rather rudimentary. I joined late, and I was just interested. Probably this has been answered before regarding constraint optimization, because this government is fond of imposing regulations, and many of the regulations that are imposed are unpredictable. So parang it's arbitrary sometimes. So that will be a problem in terms of arriving at an optimal way of distributing or rolling out the vaccines.
Mm-hmm. Yeah, you're correct. But okay, so it's okay, we need to either we need to convince the decision makers, so if they have set their objectives and this is what is being recommended, to develop policies, or to develop policies in support of that particular solution. Alternatively, if the policies are already set, or if they really need to implement that, then we need to identify what would be the best thing that we could do considering the situation.
Okay.
Yeah.
Thank you, Kathleen.
Okay. So I've got a question again for you, and this is in regard to the vaccine supply in the Philippines. So there is that amount that will arrive by June or July, about 11 million, you said. So what's the plan by the government beyond that? Because certainly the country needs more, much
Yeah.
That's a
more.
$64,000 question right now because we're just been aware of this. And so I'm trying to drum up enough excitement as well as worry from the business sector. I've asked the private sector already to see if we can crowdsource supplies, crowdsource people, doctors, private doctors to
Yeah.
assist in this upcoming deluge of vaccines. So clearly it's a joint effort, but the alarm has been sound. It's a different problem than what we're
Yeah.
facing now. And I think we need to be part of that solution, Kay and
Yeah.
Raymond.
Yeah. Sure.
I think with this new data, this really completely changes the picture. And there's no plan right now, Joel. So I think we need to come up with something in order to advise the IATF as well as the DOH on the best way forward. And that's why I asked for the pitch points definitely on your supply chain already that you did an initial analysis on. So we will need all hands on deck on this one, if
Yeah.
only to be really relevant in that sense. I mean, sorry.
Oh, it's fine. It's fine. I just want to pursue that a little bit more. But Anne, you're back, so please, you will ask your question after me. My question. Yeah.
My question to all is: are these vaccines arriving at once?
Okay, can you at least flash the table of Secretary Diary?
Oh, okay. Hold on.
That will really solve everyone's questions because you will see. And then the second is the graph in terms of utilization. At 250 jobs a day, ramping up to full utilization of the deliveries at 500,000 jobs a day.
Okay, hold
That's
on.
the critical two figures that I just vibered. I think Raymond also. I message you or direct message you on those. But I think everyone needs to see this, guys. This is as fresh as we can get it.
But that really becomes a logistics question. But my question to you, just to follow up, Al, is I know that beyond the 11 million right now, the 11 million dosage that will come in June or July, there's nothing concrete yet beyond that. But do you know, are you aware the Philippine government is in communication, I'm assuming it is, with the World Health Organization because they have this COVAX program that would make available vaccines to everybody?
Yes, Joel. Actually, my worry is that if you combine the COVAX and the contracts that are being signed right now, will be up to 148 million, something like that. Some obscene number that's over. We're over procuring at this point. If you combine the two allocations, which is worrisome because, I mean, from famine to now suddenly a glut. This is going to be a waste of tremendous amount of available money that we don't have.
My question, Al, is: are these arriving at the same time?
No, they're on schedule. The current schedule and is 7 million, 10 million, 16 million. There's a schedule already laid out by the former secretary. I'm assuming, again, I'm saying that if his data is correct, arriving 6 million in April, 7 million in May, 10 million to 11 million in June, another 10 million in July. So between those, they will expire if we don't jab them, or we don't inject them. So right now, the ramp is really very, very important for us to address. The supply chain, not only from the arrival from the airport to the provinces and administration. To me, that's the bigger problem. How do you get it to the health centers, and how do you have enough doctors with enough injectors and band-aids to inject enough people? And even actually bringing the people to, will run out of priority healthcare workers as well as overage patients. We'll need to cart people, truckloads of them, in order to accomplish this task, the way India is doing it at 2 million a day.
Okay. Is this the figure that you were talking about, or did you want the table?
Well, the table will give you the numbers initially that Anne is asking, but the second that the graph shows you at 500.
Okay, hold on.
Do the share screen, please.
Let me just open the.
It's two photos.
Okay, so not that one. Okay.
Okay.
So wait a minute.
Hi, Joel.
Hold on, let me just.
Suspense.
Okay, so this is the first one. So this is the table that you sent, Al.
Yep, there's the deliveries, guys. June, 11 million. July, 14 million. That includes COVAX supply, 34 million from COVAX. So 150 million of vaccines arriving in total.
So these are all COVAX?
By December, end of the year.
These are all COVAX or?
No, 34 million is COVAX and
the others would be a mix of all
a delivery. Again, the breakdown's right there. From AstraZeneca, J&J, Moderna, Pfizer, Gamaleya, the Russian, Sinovac.
But AstraZeneca is now suspended in European countries.
Yeah, but we ordered it already and signed the contracts already. So,
wow.
Yeah, and we're expecting 20 million of that starting in June.
So Al, you're saying that if this schedule is followed and if it actually materializes and everything is delivered on time, so by December there's going to be 148.9 million.
Correct.
Dosage.
Plus, I think plus an additional 34.7 from COVAX.
No, I think the 34 is included in the
all right.
Maybe, I don't know.
Now, but a lot of these vaccines though require 2 shots.
Yes.
Per person.
Yes.
Yeah.
So that means that that's not going to be the total individuals.
Yeah.
But yeah, I mean, you probably have just to extract Johnson & Johnson, which is at
Correct.
5 million right now for the single
So
shot.
that's still going to be probably less than the population of the Philippines.
Well, we were talking about 60 to 70 million for achieving herd immunity. So double that at 140. That's still enough. We're still over.
Right, but I heard some number now that to achieve herd immunity, there has to be about like close to 80-90%.
Yeah, and that's the other part that Edsel Salvania threw a curveball on me yesterday, saying that just because you've injected 70 or 80, if they're not transmission blocking vaccines, meaning it won't allow you to transmit the vaccine, then you won't achieve herd immunity.
Right.
Right now, there's no data about herd immunity. Everyone's just
that was my question out earlier in terms of introducing herd immunity, because ultimately that is the goal. And of course, assuming that there is that regular supply of vaccines, then of course it's a realistic goal.
Yes.
So the question now is, since this was designed to be able to vaccinate, 70% of the population, and given this time schedule here, so the question now is, how then do you allocate time-wise as well as spatially the vaccines so that you can achieve 70% vaccination, and hopefully that translates to herd immunity?
Kathy, can you flash the second slide that just sent to you? Because that will answer the part of the question that Joel just posed. So here, Joel, there's 2 scenarios that Secretary David posed. If you do 2 million jobs weekly at the rate of 290K daily, this is the accumulation. We won't be using up all the deliveries. Scenario 2, you need 500K daily. Then you'll be on top of the situation, meaning your monthly capacity to job will be right on the money using all the deliveries. How to accomplish this? He says that's the big challenge. How to deliver it, how to have enough people jobbing, how to bring enough people to be jobbed. All of those are going to be a logistical challenge.
Question. So my understanding, based on my readings, is that the local government units in the Philippines are authorized and actually tasked to come up with their vaccination plan, assuming that there are vaccines that are available.
Yes.
So what's the status of that?
Well, that's another $64,000 question that we need to answer. Make sure that what is their current capacity? Because if they're talking about the current rate that we're doing it now at 10 to 20,000, the whole country, we're not gonna get there. And that 500,000 capability to job a day is not trivial. Right now, the only guys doing that so far, I think India, China, US, with very aggressive and sophisticated healthcare systems. So right now, honestly, I'm just looking at the numbers. They're planning to do at the most 200 to 300,000 jabs when all the vaccines become available a day.
So this really requires careful planning, especially because there's going to be an election. Is that next year?
Yes. Well, the campaign started today, unofficially.
Right. So
yesterday.
there's going to be a new administration coming in part of next year, and so there's going to be a transition, and that could represent a disruption and interruption of the plan. So I think that has to be planned for carefully.
Well, that's why this one is only outlined for this year alone. Although there were already earlier tempering of expectations from IATF saying that we will have to vaccinate for a couple of years and they won't achieve herd immunity until 2023. So to me, all of those are kind of negated by this new data that we will have enough vaccines and spend enough money to procure the vaccines, only to allow them to expire and waste. So to me, that's an immediate present danger problem that I want us to be addressing in the scientific community.
I'll have one last question and then I'll turn it over to Anne. So what about, I know that there's already been some vaccines delivered in the Philippines. Can you tell us where the vaccines came from? And number two, what's the status of that? Because I heard report that they were kind of like at the airport for a long time.
Well, everyone knows pretty much that I forgot the last count. Maybe John De Castro knows it better. I know we're at the 50,000 level of vaccinations. 423 arrived from Sinovac, and there's 1 million to be expected end of the month to complement that. Astra also at 430 something. They're doing at a rate of 10 to 20,000 as of 2 days ago. I haven't seen. They're saying that they're gonna ramp up by the end of the month at 200,000.
And so who's receiving the vaccines for those?
IATF is in charge of receiving it. I forgot the private sector so far. My only news on the ground is that both Unilab as well as Willy Pharma are assisting in the logistical distribution because they do have the pharma distribution network. Between Swillig and Unilab, you probably have 80% of drug and pharma capability already in distribution.
Okay. All right. Anne, I'll turn it over to you, please.
Okay, thank you, Joel. Now, my concern here is this is really very messy in terms of logistics, considering that almost all of those vaccines require 2 doses. So even in America, it's difficult for them to really monitor those who were jabbed first dose and then to come back on time for the second dose. Now in the Philippines, I can see that to be really a nightmare. Yes,
agree, Anne.
Especially that they ordered the vaccines that are with the expiration that's coming. So if they ordered this time, usually that's 6 months, and then you have -70 for Pfizer, a degree C, and then -20 degree C for Moderna. For Sinovac, I'm not sure as to the storage temperature. And then at the same time,
2 to 8 degrees centigrade.
2 to 8 degrees. However, once you open the vial, which is equivalent to like 5 doses for J&J and Pfizer, and 10 for Moderna, they have to inject that within 6 hours.
Yep, that's the challenge.
That's
once you take them out.
It's really new to the Philippines.
So I'm just hopefully you're as stressed as I am.
So what can we do? What can we do to help?
Well, I mean, I'm asking Raymond and Kathleen, where are the pinch points so we can focus our efforts and where we can direct private sector? I would rather try to contact Philippine Business for Social Progress. They help us with the diagnostic capability with Gene Expert last year to get the Cepheid kits coming out of California to be delivered here to augment our diagnostic capability. We're gonna bet on them again because they administer the TB program with Global Fund. to help us this time on COVID vaccine deployment. And PBSP is represented by the business sector, which is
Okay.
most of the members of Makati Business Club as well as PCCR are part of PBSP and addressing national concerns on social. And this is as a priority to them as anything else before. But their experience in TB vaccines is probably in the 1 to 10 million administration. We're talking about 100 million effort in this one and a lightning speed. So this
All
is
right. Thank you, Al. Thank you, Al. I'd like to go back to Kathleen and to Fred. So tell us, what do you think would be the pinch points?
Actually, Fred had to leave because he had another meeting at 9 o'clock.
Right. Okay.
Okay, but yeah, yeah, listening to the conversation, there are several pinch points that we can actually identify. So yeah, so thank you very much for raising this particular concerns. And yes, the team can actually look into this. So it's a big team. So we intend to be in close coordination. Al, maybe yeah, you're very much in touch with our administration. So like Raymond mentioned, he's in charge of the admin side of this particular project. And I failed to inform everyone as well that we also collaborated with the Data Science Institute, which the dean of which is here with us today, Dr. Mac Cordell, and also the Animal Labs. So Dicky Gonzalez is also here, who is in charge of Animal Labs. Okay, administration means giving orders, exactly. Yeah, so maybe I'd like to call on Mac and Dicky as well. Maybe you can add a few more regarding this new arising problem. Mac, are you there? Mac, yeah.
Okay.
Yeah, also
Yep.
there are, I believe there are instructions on how we prioritize the allocation. So I believe that fine grain factors such as mentioned in the presentation and the one that you suggested as possible pinch points, these are unclear and thus remain to be an ad hoc for decision making. So yeah, I think the Data Science Institute and Animal Labs will continue to push this through perhaps the OST or LGUs, specifically in LGUs, since when we have enough available vaccines, it's more manageable to deal with LGU rather than the big government, at least from the from my perspective. Yeah, that's all.
All right. Thank you. I think Secretary Pernia is raising his hand. Secretary Pernia, please. Secretary Pernia, are you there?
Oh, maybe it was from earlier.
Oh.
Yes.
Dr. Joel, may I make a comment regarding the supply problem?
Please,
Okay.
please.
All right. My name is Romulo De Castro, Jong De Castro, with the Center for Informatics and University of San Agustin. Al, in some countries, they are mobilizing not just the healthcare workers, but healthcare students. So medical students, nursing students, medtech students, everybody, and even retired healthcare personnel, older people. Of course, we have to consider their safety. So vaccinate them first before before sending them out. And also we have Doctors to the Barrios programs, which I think we should be able to mobilize, and even civic service organizations such as the People's Coalition for the Right to Health and all those organizations. We need to bring them into the fold. I see a public-private partnership that is in place, particularly with you, Al, who's been very active. Thank you for that. But we need to include the NGOs, the social organizations, and a lot of people who are very concerned. Doing a job is not that hard. I mean, even vets can do a job. So maybe even vet students can be used to, I'm worried about the supply of syringes, of course, but I think maybe we have local capacity on that. So perhaps this is the public, private, and social organization partnerships that we need to do, not just public, private. So include the social organizations because they're clamoring out there to have a voice. And I've talked to some of them and they really want to help.
I can't help but agree with you, Jong. Dean Belisario, June Belisario of UP Manila, who's in charge of who's been advocating that. Dr. Tadvarios, of course, advocated it, and we need to be able to say, he said, one of the key issues is healthcare communications. We have to communicate this issue soon rather than later. And of course, involve everyone, all hands on deck, between NGOs, even crowdsourcing for potential supply, the same way we did crowdsourcing, John, with your help on the PPEs, with your bioinformatics team in San Agustin. That has to be multiplied in almost every city, if you think about it, by June, so that we have to make sure that there's enough people to administer, and also even the logistical requirement to bring the people to be vaccinated is equally a challenge. So you need to contact the bus companies that have unutilized capacity right now to bring in people to be vaccinated. That's the kind of mobility that we'll be doing in order to vaccinate 70 million people is no joke, guys. So, I mean, 1 million is already a challenge. But
just one suggestion, PASOK, Philippine Association of
with Tirso Ronquillo, we used him also for our PPE,
because we need to mobilize our medical and healthcare schools, and there's a ton of them in the Philippines, nursing schools.
Yes, I agree. I will definitely ask Philippine Business for Education, which is already a 700 strong university group. It's headed by Chito Salazar, and my father-in-law is chairman of that. Of course, PBSP, he's also vice chairman with MDP as chairman for Philippine Business for Social Progress. I already made him aware of this problem yesterday.
And use the vets too. Use the vets.
Yes,
well, Miranda would be probably
everyone.
All right, thank you both, Romulo and Al. Go ahead, Kathleen.
I think Vicky has something to say.
All right, then I'd like to call on Vic after that.
Hello.
Yeah, hi, good morning.
Excuse me. Yeah, I just want to say that Animal Labs is here to support Kay. I know that it looks like this work is expanding a little bit more than what we thought it would be at the start, but don't worry about the resources. We have
all right, wonderful.
Support you.
Dicky, on the crowdsourcing aspect of your startups in Animal Labs, this is probably a good exercise for them on a per city level to crowdsource, not much different from Capital. I've been mentoring Capital for 5 years. He crowdsourced from millennials to donate to farmers. We can do the same thing for this one. This time is for vaccines. I know you have a few companies that are doing a similar.
Al, if we could let Federico.
I just wanted to add something, Joan.
Yeah,
please go ahead.
I think you need to scrub up the list of potential recipients or find a way to do that, because everybody I know is in something like 2, 3, or 4 different lists of willing recipients. And everybody, of course, signs up when requested. I, for example, are in the list of my village, of Muntinlupa City, and the De La Salle list. And everyone else I know is in multiple lists. So at some point in time, they're going to find out looking for us 3 different times, and that's going to be different a waste of effort just to be told that we've already had the job. So
okay, that's a great point. That's a great point.
A little confusion going on in that area.
Right. Yeah. Thank you.
I agree, Dicky. I'm on 3 lists: UP community, my San Juan community as well in Green Hills, and the business community. So I agree with you. We need to clean up that list. Thank you.
Dr. Coelho, may I add one more?
Okay, and I'd like to go to Vic Ilag. So please go ahead. Quickly.
Just about the cleaning up of the list, Al, and I wanted to make you aware that this problem has come up in one of the discussions for AHIN. And Alvin Marcelo actually has asked that earlier, like 2 months ago, regarding where is the list for healthcare workers that are the patient registry, basically for healthcare workers, that will be injected at the beginning. And we've started talking about, where's the list for everyone else? So I think we need to put together patient registries, which we can very easily do. With some of the informatic tools everybody has. All institutions have them. So we can do those. So we need a coordinated effort for that.
All right, thank you. Okay, Vic, please. You have a comment. Could you elaborate on that, please?
Oh, comment? Oh, sorry, I didn't raise my hand. Oh, comment on the chat box. Oh, my apologies.
Correct. Yeah, it's okay. Yeah.
It's a bit out of the box, out of the, what do you call this, discussion. I understand now the complexity, but it's probably a bit controversial. Probably everybody has heard of this anti-parasite compound ivermectin, which seems to show a lot of promise. And I know there's a lot of, and it's probably an alternative worth considering. Considering it's safe, I think people consider, oh, you have to do randomized clinical trials. But this is safe. This is something which has been taken for 40 years. It's actually 10 times safer than ibuprofen or even aspirin, and has shown a lot of promise. And I think there's a recent meta-analysis. So if you just Google ivermectin, I think you'll be. And there's this other thing, I think.
Ivermectin.
Yeah, if I may comment, as one of the advocacies, Giselle and I think Al also, if he doesn't mind being included. The problem with the situation right now, while we're waiting, that the vaccine, the problem is the virus is continuously multiplying, and the current mitigations like social distancing, masking, quarantine actually does not, or these mitigation methods do not stop the virus from replicating. So with the rate this virus is replicating, and the mutation rate is like 1 every million basis, it's not surprising that actually there are a lot of variants. It's continuously multiplying. So. And there are mitigation methods. And one of the proposals we had with PAASE is to use betadine or povidone iodine. That has been shown. There are clinical trials showing that you could reduce severity as well as transmission within. So while waiting for the vaccine, that's probably something that can be incorporated, especially nowadays that there's a spike. So I don't think it's enough to just quarantine somebody or even use double, triple masks. But also, if there's a way we could promote that, I mean, we have a document detailing that, but somehow we're not getting traction or even reception among the authorities. Yeah, that's it.
Thank you, Vic. Thank you. So we have to end, but I'd like to give the last words to Kathleen and also to Anne, please. So Kathleen.
All right. So thank you everyone for joining us in this session, and thank you for providing very insightful feedback. And yeah, so our team will be looking into all those suggestions. So we will keep on working at this. Thank you for PAASE for this particular opportunity, and of course, DSI and Animal Labs for continuously supporting this particular project. So thank you for that, Joel.
Thank you, Kathleen. Anne, please.
Oh, thank you very much for participating in this dynamic session. And also, it appears to me that we have a lot of problems coming soon, especially hearing that there's about 11 million of vaccines coming. And I am concerned in a way as to what they are exactly. And at the same time, we need to see to it that the health of the Filipinos is the priority, especially during vaccination. Thank you.
All right. Yeah, so thank you all very much. And thank you for all of the input by all our PAASE members. Of course, Al Serafika, thank you for being active and being proactive in communicating with all of the government units and the private industry. That's really critical. And if every one of us could play our respective roles, I think that would go a long way. So thank you all very much. And with this, we end this webinar. We wish we had more time, but we have to end it. So thank you all very much, and have a wonderful day and have a wonderful weekend. And hopefully I'll see you next week at our next edition. And Kathleen will be back as your regular host. Thank you all.
Okay, thank you everyone.
Thank you.
Bye.
Thank you, Joel. Thank you, Kay.
Thank you to everyone.
Hi guys, stay safe and healthy.
Yes.
Thank you.
Bye
Al.
for now.
You too.
Thank